Okay, so I'm going to just get this kicked off. Thank you all so much for coming. We're very excited to have the Fall STARS Learning Collaborative. As you all know, one of the goals of STARS is to share information about evaluating dementia care programs and policies with the broader community. And the goal of this webinar is to introduce you to the Long-Term Care Data Cooperative, and share information about how to access the data and provide examples of how it could be useful to you as you evaluate dementia care programs and policies. I'm Quincy Samus. I'm a professor at Johns Hopkins. I'm one of the PIs of this center grant. And I am just really excited for this webinar. And let's go to the next slide to give some disclaimers. All right, so this is supported by the National Institute on Aging of the National Institutes of Health. Under the award, it's a U54 award. The content is solely the responsibility of the authors and does not necessarily represent the official views of the National Institutes of Health. All right, thank you. All right, so in terms of kind of this collaborative is supporting the overall mission of the STARS Center. The STARS objectives for this 5-year center grant are to facilitate state-based research on dementia care, coordination, integration, and transitions of care across settings for people who are living with dementia, as well as their caregivers. The second goal is to create and integrate within state data on home and community-based services and healthcare data. And then finally, we are charged with supporting the dissemination of findings from these partnerships and these projects that we will be funding through the center. And if you want some more information, you are welcome to visit us at starcenter.org, or you can use the QR code here. Okay. So in terms of a little bit of housekeeping, we would love for you to use the Q&A box in the Zoom. The questions will be addressed at the end of the webinar, and I'll be monitoring that. Any follow-up questions that you might have after this session, or any comments related to the session or to ideas for future sessions, can be directed to our email address at starcenter@umn.edu. After this webinar, please do take a few minutes just to fill out the brief survey to let us know how we're doing. This webinar is being recorded and will be posted at starcenter.org for later. Okay, so in terms of, I just wanted to welcome our two presenters. We have Stephanie Kassam, who is the Executive Director of the Long-Term Data Cooperative at the American Healthcare Association, as well as Dr. Vincent Moore, who is Professor of Health Services and Policy and Practice at Brown University School of Public Health. So we very much welcome you to this webinar, and thank you so much for joining us. And let's go to the next slide and get this kicked off. Again, please put your questions in the Q&A and we'll be monitoring that. All right, turning it over to you all.
Thanks so much. I'll be doing the first couple of slides. So I'm really appreciate the chance to present to all of you. And maybe this is an introduction. Maybe you've heard about the Long-Term Care Data Cooperative before. We are funded under, the Long-Term Care Data Cooperative is part of the Impact Collaboratory. And if you don't know about that, I encourage you to go to their website. And so Vince is the one of the PIs for that, and the American Healthcare Association is a sub-awardee to run the governance of the Long-Term Care Data Cooperative. So if you go to the next slide, I'll start introducing what we are. We gather clinical electronic health record data from skilled nursing facilities and assisted living for 4 key purposes: healthcare operations, because we provide feedback reports to providers; public health surveillance; research on effectiveness; and clinical and pragmatic trials. And I've starred the research on effectiveness. Maybe I should be starring the clinical and pragmatic trials bullet as well, because my understanding is STARS Dementia Care Innovation Grants may have components that could be evaluated using the data cooperative. We are also, the NIA Impact Collaboratory is also funded under a U54, so I want to note that on this slide. If you go to the next slide, we have this clinical EHR data because it's a source of real-world data that can help contribute to answering new kinds of research questions that aren't available to answer through MDS or claims data alone. So we have daily resident census from the the skilled nursing and assisted living organizations that are voluntarily participating in the data cooperative. So I can talk a little bit about that as well in a minute. But the kinds of data we have are daily resident census, vitals like blood pressure, heart rate, respiration rate, oxygen, temperature, pain, height and weight, and blood glucose measurements, immunization records, orders for advanced directives, and soon all kinds of orders, in diagnoses, lab orders and results, which include point of care testing and results from externally contracted labs. MDS assessments, so all the assessment items that are on an MDS also are presented in the electronic health record data, in addition to some cognitive assessments and functional assessments that are outside of the MDS periods, medication orders and medication administration records. And we're looking to expand. So if there's a record type that you're wondering about, please let me know, and we can see where that might fit in on the queue of what goes into our core data model. The data in the Long-Term Care Data Cooperative is electronic health record data only, but we also participate in the NIA linkage program, which means you can get resident level match data to Medicare and Medicaid claims, in addition to a number of other CMS file types, which I think are in the next slide. So if we go to the next slide, NIA data linkage enables us or anyone to take a person that is present in the electronic health record data from SNFs or assisted living. We have data from 2019 to approximately the present time. So it's a 3-month lag. And so anyone who has appeared in one of those kinds of facilities in that time period, you can apply and enter into a data use agreement to use the data cooperative data and linked NIA data linkage data for any of these file types for a date range that your study might need. And so the date range could precede 2019 and precede a stay in a SNF or assisted living, and it could follow someone's discharge from one of those settings. And if you go to the next slide, I want to talk a little bit, before I turn it over to Vince, I want to talk a little bit about who can use the data, and then Vince will talk about the kinds of research questions that we see as possible. And we would love to hear from you all what your projects might look like, and what possibilities you see and the value you see in using these data to evaluate effectiveness of a program or policy. So eligible US-based researchers can apply. Researchers is a pretty broad definition of academic researchers, healthcare organizations, other government organizations. The data are organized as easily linkable flat files, and they are stored in the data enclave. That's the same enclave that linkage uses. So everything is available in a cloud-based secure environment where we have SAS, Stata, and R available for you to work with these files. We encourage anybody who's thinking about using the EHR only data or EHR claims linked data to attend a linkage bootcamp session to get tips for working with large data sets in this environment. And I'll talk at towards the end of the presentation more about the application process to use the data for research purposes. So how do we get these data? First, as I mentioned, we're an NIA awardee, and through Brown University, that is the prime awardee for the Impact Collaboratory. ACA-NCAL, which is a trade association representing over 15,000 long-term care organizations that serve both older adults in the skilled nursing and assisted living population, as well as individuals with intellectual and developmental disabilities. We serve over 15,000 of those kinds of facilities in our membership organization. And so we serve as the governance body for this effort. We have relationships with two of the largest electronic health record vendors that serve skilled nursing facilities, and some of their organizations that have contracts for their skilled nursing facilities and also have assisted living use the same EHR for their assisted living organizations. So those Matrix Care and Point Click Care are those two main EHR vendors. And the way it works is that when a long-term care organization says, yes, I'd like to participate in the data cooperative, that organization gives permission or signs a data release form that communicates to Matrix Care or Point Click Care, yes, we would like for you to share our residents' electronic health record data on our behalf with the data cooperative. Acumen is our data engineering firm. Acumen is also the contractor for NIA linkage. That's why all of the data are housed in the same enclave. I think you can go to the next slide. We have 203 organizations participating so far, and which means that we have over 3,000 SNFs enrolled, actually almost over 3,500 SNFs enrolled, but data are around 3,000 in the data set so far. And similarly, over 1,000 assisted living communities enrolled, data on about 800 facilities in the data set so far. These facilities are in 48 states and District of Columbia. We are continuing to recruit long-term care organizations. Once an organization joins, all of the assisted living and skilled nursing facilities that are affiliated with that organization, their data comes into the data set. So we don't do individual facilities one by one. We get an entire organization's facilities. And we can talk to organizations in your state if you would like to use these data, their data in an evaluation and access that data through the data cooperative. Rather than, and the value proposition to them is you're not asking them to access their EHR directly, for example, in order to collect, or you're not asking them for them to extract data for your research purposes. So if you go to the next slide, where we are in the country as of the July 7th data set, and we just created an October data set, so this is a little bit outdated. This map is a little bit outdated. But you can see as of October, we've got 3.9 million SNF residents and over 2,900 SNFs in the data set itself. And this is where they are. And if you go to the next slide, I've got some sense to give you a sense of where the concentration of facilities are. So Indiana has the highest proportion of their facilities participating in the data cooperative at 63%. Iowa and North Carolina come in next at 35%. Ohio and Michigan is 31%. And the denominators for this are all from Kaiser Family Foundation. And so it's pretty good penetration in 5 states, pretty low penetration. These maps are on our website at ltcdatacooperative.org, and I can put that, you'll see that link later on in the presentation too. These maps are there on the website, and so you can get a sense of what our concentration is in other states as well. But like I said, we're always looking to expand. So we'd love to work with you on that. If you go to the next slide, we have a map of the density of assisted living communities that have data in the data cooperative. And again, it's much lighter because many fewer assisted living communities, but we're making a big push to increase this number as well. We are bringing on a third electronic health record vendor, Yardi, that serves an assisted living and senior housing population. And so anybody with any organization that uses Yardi and has Yardi as their EHR vendor in their communities can sign up and have data flow right from Yardi. And we're happy to talk to other EHR vendors that are serving mostly assisted living population as well. And we're piloting a process by which provider organizations can deliver their data or extract the data and so that it goes into our common data model directly. No promises, but we're looking for ways to make this data set as comprehensive nationally as possible. So if we go to the next slide, one question we often get from researchers and from our state affiliates that are looking to recruit more organizations to participate in the data cooperative is, can I find out if organization A is participating? Can I get this, my Sunnyside Health Center's data from the data cooperative? We don't advertise who is participating. It's part of our agreement with all the participating organizations, but we can work with you to confidentially confirm that an organization you are working with is or isn't part of the data cooperative, because we do want to not be a mystery and want to make you more sure that using the data cooperative would be a feasible way of getting data for the organizations that maybe are affected by your policies and programs that you're looking to evaluate. If you go to the next slide, I would love to partner with anybody who has an interest in working with provider organizations in developing a research study or wanting organizations to participate in an existing research study that might be able to use long-term care data cooperative data. We can supply content so that you can advertise the existence of the data cooperative in newsletters. We want to work with HCA and leading age state affiliates to feature the data cooperative in upcoming meetings and communications. And we want to make sure local researchers who are interested in doing nursing home and assisted living studies or focus studies or studies that focus on the population that live in those settings know about the opportunities to use these data. So we're here. We're really excited to hear from you all, and research, and and any researchers that that might want to use these data. Please let them know. We have a newsletter that goes out to researchers every couple of months. We like to advertise different research grant opportunities and developments in our core data model, and also the types, the data elements and variables that are in the data set. We'd like to advertise that there, and we want to make sure that you all know when we've got updates to CMS data and the linked data. We want to know what kinds of projects you're thinking about, because one of the goals for the Impact Collaboratory is to make it easier for our nursing home and assisted living partners to more easily participate in research. And we want to create a community where we can connect researchers and providers. So we're trying to do that in a number of ways. We have quarterly town halls with providers where they get to give feedback to researchers on some ideas about feasibility or priority for them about different projects. So we're really looking to create this community here. So I'm going to turn it over to Vince and to talk about the opportunities for participants and researchers.
Well, thanks very much, Stephanie. So it's a delight to be here to talk to you all. And my role is to sort of give you some idea about how the data can be used, what are the research focuses. I'm a researcher. I do both observational studies, pharmacoepidemiological studies, policy studies, as well as clinical trials in the nursing home setting. Have been doing it for many, many years. Having this data structure, we hope will make it easier for providers to participate in research. Let's say you are working with 4 or 5 nursing homes who want to work together as a consortium to test out ideas for a particular program, some kind of quality improvement program, let's say trying to reduce antipsychotic use or trying to increase the use of non-Part A physical therapy that is not during an individual benefit, or some kind of nutrition program. It would be perfectly possible to have all of those folks join the data co-op, wait for their data to sort of get in there and be matured, and then to start actually doing the implementation, maybe one at a time of these different programs, and then to monitor selected parameters in the data, whether that's weight, if it's a nutrition program, or it's hospital stays, if it's not something else, or it's the actual administration of the medication order. And those are readily extracted from the data and can be monitored at the individual patient level, and of course can be aggregated up to the level of the individual facility, making it possible to put together a consortium of engaged providers willing to do coordinated QI work, perhaps together with the state or together with a local researcher. And having these data available make it hugely less burdensome for them to be involved in this whole process. And that's really important. One of the things that Stephanie didn't mention is that ACA is working with many states and the state groups there to develop networks of providers that become networks because they can then sort of join together as part of their negotiation with Medicare Advantage plans, with insurers. And as part of that, they have to have some kind of network function, and one part of the network function is data sharing. So there are already a number of these programs, and some of them, for example, in Iowa, that's right. They're actually a clinical trial has emerged from that group, and they're actually testing a clinical trial related to foregoing antibiotics for patients who have a very high probability of dying, who have also dementia. So that's a real clinical trial, cluster assigned, and so on and so forth. And the facilities are all engaged in that process, and the data sort of come out naturally from that process. Obviously, researchers, some of the people on the line may already have a relationship. In Indiana, our colleagues at Indiana University and the medical school have enormously wonderful relationships with many of the nursing homes in Indiana. But as you can see, we have 65%, but it would be very nice to get to 100%. And so if there's other researchers working with others, it is free for them to join. It costs them nothing. They just have to authorize their vendor to do that. As importantly, for the researcher who's working with the nursing homes, it costs you nothing to actually have access to these data. NIA makes these data available as part of the Impact Data Collaboratory, which is the way in which this whole thing has been funded. So this is a data infrastructure that is incredibly rich. It's sort of like having an HRS or a National Health and Aging Trend Study, all about nursing homes and with all of this detailed data that's available. So it's completely unique in that respect. We spent a lot of time when we were designing this whole thing, how much would the price be, what the payback would be, so on and so forth. And after a while, we just said, it's going to be free. And NIA said yes, which is just wonderful, which means that if you follow the application process that Stephanie will describe later, then you can get approval for these data, whether it's EMR only or the linked data. And then you can ask your questions with the nursing homes and or independently of that in some kind of comparative effectiveness. As importantly, the researchers can link primary data that they may be collecting. This is really crucial. Now, you have to get permission from the provider to be able to do the individual linkage, but you don't need to get permission from the individual patient. That's key. So, for instance, if you've got patients who have agreed to wear some kind of wearable or some kind of blood pressure monitor or some other kind of clinical phenomenon, and you know that there's data on blood sugar, or you know there's data on temperature and et cetera, and blood pressure that's collected daily or weekly by the nursing home, that then becomes an outcome for you to look at when you have all of these other wearables that you can look at. And so that, for really detailed studies, we've had somebody do that with one of our impact collaboratory pilots. They had ended up just linking 10 or 12 different nursing homes for a daily wearable in terms of the blood sugar level, and then they were able to compare it to what the blood sugar levels were that were embedded, already recorded in the EMR. So there are just so many different examples of that because of this linkage. Can I have the next slide, please? Okay, so for types of research, Stephanie mentioned that we have work that is basically reports back to the individual facilities, that sort of provider operations. We're now working and have worked with the CDC. If the government ever gets back into business, they have ongoing access to this, and they're monitoring vaccine use, and they're actually monitoring the way in which one can understand which vaccines are both effective, as well as what providers are administering higher or lower proportions of their residents with vaccines. So that issue is a really key notion, and CDC for monitoring, for sort of health monitoring, is engaged in that process, and we are working with them, and there's other nursing homes as well. There's then comparative effectiveness observational studies. You could do that retroactively back to 2019, because that's virtually all of the facilities have data back to 2019, which means you could look at an individual facility over a long period of time and say, okay, this facility began to use this diagnostic test or point of care testing. And you could say, well, what happens in terms of the volume of testing, or does that have any benefit or any outcome with respect to reducing the likelihood that the person's going to the emergency department where those tests might otherwise be done? All that can be done if you actually watch from the data, and you're asking a retrospective question about the comparative effectiveness of introducing either a new treatment or a new policy, et cetera. There are, from a pharmacoepi perspective, there are a number of different studies that are underway right now comparing different treatments or different styles of, let's say, diabetes management. And the style of diabetes management is defined based on the medication administration record, and it's then you compare patients getting one style versus the other style, whether it's in the same home or across multiple homes, and see how that works. The other really key issue here is with millions of patients with this level of detail, you can actually look at some relatively rare conditions that are really important to understand. And remember, most people haven't written lots and lots of papers that are clinical like this about this population. Or if they have, it's only in the academic medical centers or in geriatric clinics, et cetera. So that level of detail is really important. It's the comparative effectiveness studies that are for observational purposes. Then there's obviously clinical and pragmatic trials. We are working closely with a group, another national NIA consortium of researchers, which is called Next Steps. And their goal is to try to increase the number of geriatricians and geriatric researchers who are interested in doing clinical trials in the nursing home, both drug trials as well as non-drug trials. Both those that require consent of the patient because you're doing more work and you'd have a smaller number of nursing homes provided, as well as those that are where you might even randomly assign nursing home A versus nursing home B, sort of what's called cluster random assignment. And so those big trials are there. So just to give you an example of one kind of trial that we've done and could be done even better in this kind of environment. In fact, I believe my colleagues are in the process of doing it. We did a series of trials before COVID looking at whether high dose versus standard dose influenza vaccine was beneficial for older people living in nursing homes. We knew they were effective. FDA had already approved them. The question is, so what difference does it make in this population that is never subjected to these kinds of clinical trials? And we found that we enrolled 400 nursing homes to get the high dose and 400 nursing homes randomly assigned to get the standard dose. And then we waited around for hospitalization. Now that we have these data, we don't have to wait anymore. We could actually look at functional outcomes. We can look at medication outcomes. We can look at temperature to see whether or not there's a big bolus of high temperature after the administration of the vaccine. So those are all the different kinds of questions you could do under a trial. Next slide, please. So this just gives you, I can't even tell you how many different outcomes there are. But obviously there's medication use, and it's not, if you're used to working with Medicare data, this is not, did you get a prescription filled? This is, did somebody actually administer this drug? This is nursing administration records, and it's all automated on the file. You have the order, it's linked to the administration, and if ultimately you want to find out what proportion of prescribed drugs weren't actually given, or so on and so forth, you could do that as well. But having the exact administration means that the precision with which you can ask pharmacological questions is really, for comparative effectiveness, is really much better. Having an advanced directive in the order, whether or not the advanced directive is actually effective in reducing the risk of a hospital stay or an ED visit. Those are the kinds of things that might be very important. With the information on assisted living, there are many of the facilities that are assisted living in our network which have a direct linkage or are part of the same organization and are co-located with a nursing home. So you can begin looking at people moving back and forth from these kinds of events, and then with the linked data, you'll know that they were hospitalized perhaps as a precursor to that transition. And no, those kinds of things have generally not been well characterized because the data haven't been there at this level of detail. Hospital transfers is there. We've just finished doing some validity and reliability work. When you crosswalk the hospitalization record from the census record that's in the EHR, it corresponds very highly to the existence of a Medicare claim in the Medicare data, which is something we never knew before. That paper is being pulled together right now. So the level of and the mortality is also a spectacularly strong link, meaning that we can be relatively confident that if there's a death, not just in the nursing home, but shortly thereafter. So we're capturing a lot of that stuff. And with the linkage, as I mentioned, everything is there. So with the linkage data, you could also begin to say, let's look at that hospice event during the nursing home stay, which otherwise is hard to get if you're just looking at the MDS data. You need to link it together. And then you could say, was it preceded by an advanced care directive or something like that? And these are really crucial questions that we need to look at in order to understand how this process works, and so that the nursing homes themselves will be in a better position to learn from their own experience, and having this relationship with embedded researchers, with researchers doing that, helps everyone learn from that process. Next slide. And I'm going to turn it back to Stephanie. Is that right here now?
Yeah, I think I lost the slides. I'm not sure. I'm not seeing them anymore.
Okay.
I can see them. Can you all see them?
Oh,
How do dementia programs influence? Yeah, so these are just examples of how you can use it. So how do dementia care programs influence time to nursing home admission for assisted living residents? So they came into an assisted living, and yet then whether you're asking the data from the linkage or you're asking the data from the from the EHR data, you can see how the number of days that elapse. And so you can use some kind of survival model to look at that. And that's a really key notion, because it's not often a permanent admission. There's a bounce back that happens in that process, which is as I described before. Are patients with dementia discharged from SNF more or less likely to receive home health care? That's a question we can answer with the big claims data, but here we can find out more about what kind of rehab they got, how much, did they have other kinds of hassles or problems while they were in the nursing home that might have influenced that outcome of getting home health. How does prior receipt of Medicare home health visits influence the timing of when people enter nursing homes? So again, for states, you care about, many states are making very significant investments in their home and community-based services. With home health visits, we have one view of that. I know there are some states out there that have home care, not home health, but home care data. And at some point, it might be possible to think about linking those data together with these data to make this possible. So for a longer term subject, but if there's anybody from any state that has that, we are happy to talk to you about the mechanisms by which that could work, because that will help states understand whether the investment they're making in home and community-based services is actually saving on the Medicaid funding that's much higher costs associated with people becoming long-stay nursing home residents. Next slide. And this is the last of my slides. So how different are patients' medications received in the Part A fills after discharge? So we can see while somebody is in the nursing home, which you cannot see now with the Medicaid Part D claims, because that's all part of the nursing home's bill. So we can see with medication administration what they're getting. And then, of course, you say they've now been discharged. What is the fill pattern? What's missing? What got dropped? What got added? Because some things often get dropped, and it's, the primary care doc loses, loses track of what happened, or the incorrect information gets transmitted off to the community pharmacy, and or something doesn't get delivered and it's not thought of in time, or the family member doesn't pick up. All of these discontinuities can happen that could have a really exacerbating effect. And there are strategies in our US healthcare system that could be modified to minimize the chance of that happening. And the way to understand that is to do these kinds of studies. How prevalent and how effective are least restrictive diabetes plans? That's sort of what I described before. This is what we're trying to do right now, where you not go to insulin, to stay at a different level with a diet modification and or with exercise to go with that. How are those things going, and does that give you as much protection as does an insulin approach? And then finally, how effective is the introduction, let's say, of a PCR test for detecting UTIs? We do have point of care testing, and if you can detect a UTI early, you're going to prevent the ED visit when it gets exacerbated. And there are all of these things associated with that, and because bad things happen when little old ladies go to emergency rooms. And so there are so many different questions. As I tell my students who work with just Medicare claims data, the biggest restriction that people have in using these kinds of data is their own imagination. And having more people with their own imaginations use these data, I can't come up with all the questions. Other people have to. So back to you, Stephanie.
Thank you. And so the Long-Term Care Data Cooperative offers researchers this great benefit. I saw a question in the Q&A about where the funding for this is coming from and how long it's funded for. So the funding is through an NIA grant to the Impact Collaboratory, which just got a 5-year renewal starting September 1st, 2025. So that's one answer, but this is an infrastructure we are hoping to find ways to sustain. And what we're hoping to do is that you all can encourage long-term care organizations to participate in the data cooperative and encourage them so that you can do the state policy and program evaluations, and so that perhaps it would be interesting to study for your state if your state facilities get custom feedback reports to support state-specific priorities. So when I say custom feedback reports, I mean facility-specific reports on what is documented in the EHR in terms of the use of antipsychotic medications or anything else that might be other kinds of treatments that might be something that you want to monitor. You want to make sure that there's a good use of perhaps an attempt to treat in place, and you have an intervention to see if nursing home staff can treat in place what's possible to treat in place in an assisted living or a nursing home, and you want to see what effects that's having. And maybe you want to start by educating the facilities where their hospitalization rate is now. They probably are aware of that, but we can slice and dice this for at a more granular level with the EHR data than you can get from DS quality measures, for example. So if you're interested in promoting this to providers in your state, please again let me know. As Vince said, it's free for providers to join. It's free for researchers to use. If you go to the next slide, I talk a little bit more about this is an feedback report to providers, and this is one of the ones that we did on just who has advanced directive orders in your building, and more specifically, how are those advanced directive orders being documented in your EHR, and how does a facility compare to other facilities in the organization or compare to all the facilities in the data cooperative. This is an example of a report that is not very nuanced, right? But we want to give some kind of gross data, some high level data, and start the conversation and see what's really helpful. So if you go to the next slide, I want to talk a little bit about the application process. So we have a 2-step process. First, if you can submit your plain language abstract, we have a structured plain language abstract template on our website. We screen for eligibility and feasibility. And the eligibility part of it is, are you proposing to do a study that is a comparative effectiveness or clinical or pragmatic trial, and use the data for that? Those are the 2 types of studies that we can consider. For feasibility, we look to see what kinds of data elements you would need, and we can do some initial analysis to say, okay, if you need this particular lab test, or done, we can see how many facilities have the data for that particular lab test. Because one caveat we have not said yet is EHR data are very messy, and organizations use their EHR in different ways, we are finding. So it's important for you to kind of do the initial scan of who's going to have the data documented in the way that you can read it out for your data analysis. So we have a eligibility and feasibility review. Then the same plain language abstract goes on to receive comments on content. That's a 8 business day total process. And then we give you a chance to, if you need to respond to comments, to tighten up this plain language abstract so that it is provider ready. That's our goal, is helping you get the most positive feedback you can from the providers who are involved in reviewing the applications. And there's 2 parts of reviewing the application. One, you can see on the top purple arrow, is after you submit the final plain language abstract, which might take longer than 8 business days, because 8 business days is the review, then you have time to revise. But after you submit it again officially with your application, the plain language abstract goes to community comment. And this is all representatives from all the long-term care data cooperative participating organizations. People can say, yes, I love this study. This is exactly what I've been looking for. Or no, this doesn't make any sense to me. This would be useless to me. That's kind of brutal, if depending on what your topic is, what kind of feedback you get. But this is the kind of honest, candid interaction we want to have between researchers and providers, and hopefully we learn from each other. But that's not the deciding group. The deciding group is the Research Review Committee. And this is a group that is a majority provider. So again, this is why the provider-facing part of the plain language abstract is really important. And they get the community comments, so they can bring those perspectives into balance with what their individual inclination would be towards a particular topic, and they make a recommendation to approve or not. And so total, we aim for a 20 business days in which the application sits with us. And so we hope to be pretty responsive to those that are making an application. You go to the next slide. Here is the structured abstract requirements, and I won't, since looking at the time, I won't spend too much time on this, but we do have some guidance on how to make it plain language, and but also respecting the fact that the people who are looking at this do wonder about risk adjustment and how are you going to make sure you're comparing similar type patients in your intervention and control groups and whatnot. So if you go to the next slide, the Research Review Committee, as I mentioned, we've got like 6 data cooperative participants, another provider representative that's also on the advisory committee, and then a couple of representatives. And the evaluation criteria are, does it align with the mission, which is to do comparative effectiveness and promote clinical and pragmatic trials, and ease with which those can be conducted. Is the study proposing to use data elements that would be sufficient to accomplish the study objectives? So that's kind of the feasibility part of it. So it's eligibility and feasibility are the evaluation criteria. The members of the Research Review Committee are posted on our website. They're about to refresh. So it's not, as of a couple of days ago, that particular list of names is out of date, but it'll give you a sense of who's in the mix. If you go to the next slide, if you want to use linked data, there's the NII linkage has its own process for requesting a data use agreement for those Medicare, Medicaid claims and other CMS files. If you go to the next slide, great, we are here. And so now I'm going to go to the Q&A because I haven't answered all of these. One of the questions is, if specific SNFs and assisted livings are not identified, what is the smallest spatial scale that the data is organized? County, regional, state, or some other level? So with every facility ID that you see in the data, so you can know, track facility IDs across time and across data sets, there's the smallest identifier is state or zip3. We can, of course, make that unmasked if you have the facility's permission to analyze their data within the data cooperative, and you need to know a specific if you need to know that a specific facility ID is in your study, for example, or if you're just studying one facility, we can also look at that. Let's see.
So I should note, Stephanie, that if you go with the linkage, the data on linkage, because there's an extra level of CMS oversight and requirement and the privacy board review, you actually get individual information on, so you'll know exactly the provider number because you need to know provider number X and provider number Y, but you can't do anything with those data other than do the analysis in place. You cannot extract them. You can't take them away. It's hidden. That's why they're on a centralized repository. So it is, and you basically have to sign away saying, I'm not going to have a listing file of provider numbers or a listing file of patient IDs. This is standard stuff working with these kinds of data. But the EHR only has some restrictions around what's available, which is perfectly reasonable. But the linked data, you have much more access to everything, and but there are the penalties are significant there because you're going against the government then.
Another question I see is, what have been the effective selling points among participating long-term care providers? And how do you address any state-level data sharing regulations in addition to HIPAA? So, effective selling points to participating long-term care data cooperative providers have been, or long-term care providers, are that, one, often it's that they are participating in these state networks that it's developing, and they want to be part of, they want to make sure that they're doing the data sharing, as Vince explained, that's necessary for that to demonstrate clinical integration and working together on quality improvement projects on specific measures and that kind of thing. So that has really been the best selling point we've had in some states. And I can let you know after if you have questions on where those networks are in specific states, I can let you know those. Not every provider is going to be participating in those networks, but that's one. The other is really an appeal to what's in the best interest of the sector. And we really try to make the case that by having this carrot of a cool data set that researchers would never have had access to without the NIA's participation and funding, without long-term care organizations participation, and that because we're offering this carrot, what we ask in return is that researchers do figure out what works to improve resident outcomes. And what one facility might think of as like the most important resident outcome they want to improve, and what they need to understand about more effective medication management or use of medical equipment or something like that in the setting. Okay, maybe a researcher will pick that topic, or maybe they won't, and it's going to be a topic that's more important to another facility and that what they think is their highest priority. But collectively, if we have enough researchers using the data, we will get some answers that are actionable. And that's why we really are trying to promote this among ACA members, ACA non-members. This is open to everybody to participate in, because we think it can be so valuable to answer questions about policy effectiveness and about clinical effectiveness. And so there's as Ben said, you're only limited by your imagination, and so sometimes that appeal actually does work to the greater good. The question about how do we address state-level data sharing regulations in addition to HIPAA, we don't. So I'd be interested to know if there are data types that you're thinking about that that I'm not aware of. But for example, we don't have genetic information on facilities. So I'm thinking about the kinds of state-specific laws that there might be that would require individual consent. But essentially, we act as a business associate of the participating provider organizations to both prepare the data for custom feedback reports and also prepare the data for research use. So we are acting like any other data vendor that a provider organization would use.
That's great, Stephanie and
Yeah.
Vincent. That this has been so great, and I don't see any more comments yet, but I have a couple of questions. So in terms of kind of like the kind of the provider or the organization level, do you have data on characteristics of each individual facility? So for-profit, nonprofit, all of that kind, type of facility, that kind of stuff.
We have recently provided a crosswalk from facility ID to the provider information file that CMS makes available, which has all of that information. Yeah.
And so does that include like SNFs and assisted living?
So that's a great question. That is only SNFs, because but it has their payroll-based journal information, their quality measure information, their for assisted living, we do not collect facility characteristic information as part of this EHR. I mean, what you would get, what it would be the number of residents that are there. You'd get the average census, and that could tell you something, and their state. That's it. So, but we really welcome creative ideas for how we might link to assisted living.
Yeah, actually,
facility
this is a state engagement. This is a state group. There are many states that actually do have often different bits of data on their licensed and or certified assisted living facilities, and so that would be a source of potential integration, and that might be made available in some way if you can work with your states to put something like that together. It would certainly enhance the quality of the importance of the data.
That's awesome. And then here's another question that just came through that I can see. It's for the data linking, does consent from providers have to be given before the primary data collection effort? And so how would a state link already collected data at the provider or patient level with the data cooperative?
Yeah, we can get that permission after it's been collected. Mm-hmm.
Gotcha. And to link the data cooperative, what info would be collected, I guess, at the provider and patient and facility level?
So at the patient level, we can do, if you know where the facility is, where the patient is located, so facility address, sex, birth year, date of birth, we can actually use because we do have that. By default, you only get birth year. But again, we can, if your IRB approves, we can do more granular than that. But if you produce a finder file with some of those key data elements, we can use that to match to cohort. I should say that matching process to a specific finder file, there is a cost list on our website.
Gotcha.
That part, it is not part of our standard data access package. So, but we do try to make the costs of those kinds of custom requests transparent to you so that you can budget that out.
Yeah, that's very, very good you said that, because I mean, while it's free for lots of first, if you're doing a trial and you're needing help in recruiting facilities and all this, that there's a price to doing that. I mean, but you don't, the cost is not extracting the data. The cost is actually doing the trial.
Thank you. Thank you. Oh, so we have like 2 minutes left. Sally Opale, let's see if we can get you so that you can ask your question really quickly. We only have like 90 seconds left. Let's see. Did I unmute her? I don't know. I don't know how.
I can't see her question.
I don't know if we even do this during this webinar.
Yeah, the host has to unmute her. So unless she can unmute herself.
Sent a request to unmute.
Okay, well.
All right.
You can send us an email, Sally.
Yes.
Yep,
Yeah,
yep.
Sally, sorry if we can't get you to talk, or you can put it in the chat real quick. But this has been absolutely wonderful. Like, just one more question to wrap it up. In terms of consulting about an idea, are you all available for that? And then second part of that is, once somebody, kind of submits their request or their idea for the LTC cooperative, do you track like the results, and do you share those with your networks?
Oh, yes, we are really interested. That's why I'm in this, is I am super excited to get some results and promote it out to the data cooperative and to all of as many nursing home audience as we can. So, and assisted living audience as we can. We really want this to be, I think Vincent said, a learning network. And that's what we also hope people are in it for. So. But in terms of being available, so there is a link on our website, a contact us link on our website, or LTC Data Cooperative at hca.org, or my email address, which I can't put into the chat here, but maybe others can. Anyway, we are definitely available to talk through some ideas and hopefully get you on your way in a pretty quick manner.
Well, thank you both so much for joining us at this very exciting webinar. I bet you're going to have a lot of questions and hopefully a lot of interest after this. So thank you so much. And everybody, if you have more questions, please email the Star Center or you can email them directly. We will have a recording on the website. Thank you all. Have a great afternoon.
Bye-bye.
Thank you.
Thanks, everybody.